is about the development of a recurrent neural network to predict renal function impairment in diabetic patients using longitudinal routine checkup data. So, as you probably all know, diabetes is unfortunately a very severe chronic disease characterized obviously by elevated blood glucose levels, which may lead to a plethora of life-threatening complications. Again, as you probably know, diabetes is incurable, but it is treatable. And all treatments have the same goal. They need to stave off complications, of which unfortunately there are many, because we've got cardiovascular disease, we've got neuropathy, permanent blindness due to retinopathy, and lower limb amputation, and obviously kidney disease, which is the topic of my presentation. In fact, kidney disease is the leading cause, and well, kidney as well, is a let's say diabetes is the leading cause of end-stage kidney disease. That is, if you walk up to someone who's on dialysis, odds are that they are on dialysis because they have diabetes, which obviously paints a kind of a bleak picture. But luckily for us, there's some good news. There are lots of intervention targets. So you can do something about CKD before it starts or while it is in progress. Even better news, a recently introduced class of anti-diabetic medications, that is the SGLT2 inhibitors, have been shown to stop the progression of CKD in people who already have kidney issues. And finally, this is even better news, the same class of medication has shown that they can prevent the onset of CKD even if there is no sign of it yet. Unfortunately, we are confronted with the usual open issue, because to capitalize on this good news, we will need to find out who is actually at risk for kidney disease way before they develop it. Because the alternative, for instance, you're reading the good news over here, and you might think, well, let's give everyone SGLT2 inhibitors, is unfeasible because it does not make any medical sense, and it makes no economic sense in any way because they're very expensive. Hence, the objective of this work, it was to develop a predictive model of renal function impairment in diabetic patients whose renal function is still preserved. And we wanted to do that using routinely acquired longitudinal data. So lots of qualifiers in there. Let me explain why I need so many of them. At the moment, at least in Italy, where the study is based, one-shot measurement of eGFR is the only risk factor that is considered for kidney disease in diabetes. Although medical doctors have access to any test they want in principle, except since there is no true multivariate gold standard, they cannot prescribe whatever they want. So they need to stick to the guidelines, otherwise the test is not reimbursed. And this means that while we wait for a massive clinical trial that will come up with a multivariate gold standard, we are stuck with the way that the data are, and we can't influence data collection in any way, which is a critical point if you think about it, because as methodologists, what we want is to live in this ideal world where we have a nice little baseline, no missing data, all the variables have been acquired at the same exact moment in time, then we stop observing the subject, follow-up starts immediately, and we know with frequent sampling whatever happens to the patient. So now the outcome is the onset of kidney disease. Well, we follow up on the patient. The patient is fine until some point in time. Then, unfortunately, their kidneys break. And so we know, continuous time, what happened there. Unfortunately, the reality, as I am sure have experienced, is that we don't have the baseline. Instead, in the real world, we've got a sequence of irregularly sampled visits. So visit 1 is there, then visit 2, 3, then here the patient skipped a couple of visits, and then we got visit 4, and then they skipped 3, and we got visit 5 over there. And we somehow need to make sense of all this. Worse than that, it might happen that some patients have different number of visits, right? Because maybe the next patient has 6, and so we need to mask the 6th visit for this patient here, who only has 5, so that we can input this data into a model. And so this is for the input, but it's not over yet, because even if we do have visits, often we end up with missing data, because again, doctors cannot prescribe whatever they want. They need to stick to guidelines. And the same thing happens on the other side. of the baseline. So when we look at follow-up, we cannot continuously sample this person's kidneys. We need to, wait for them to show up, assess their kidney status, and for instance here, for a while they were fine, then we wait for them to come, and so that we see them again. We find out that on the next visit, well, the kidneys had failed, but we don't know exactly when between the blue and the red portion of the data. So this is a situation, right? So we've got an input, which is frankly a mess, and an output, which is kind of undefined. It's got extreme interval censoring in there, and we were forced to move on from survival analysis, so with the exact time of the onset, and prefer a multi-label approach where we divide the follow-up into 7 years, those 7 boxes, and try and figure out what was wrong or right with the patient at that time. So that's the theory. Let's see the actual data. So we're talking about the data of about 29,000 people with diabetes, and these data were collected in 14 diabetes outpatient clinics in the northeast of Italy. The Veneto region is where Venice is, if you've ever visited. So here's the data set. I will skip through the boring parts. It is we split everything, train validation and test set, 8%, 10%, 10%, because we all know how that works. And we'll focus on the important things. That is, these data are real data because we couldn't alter the data requisition protocol. So you see there the typical profile of a patient with diabetes, predominantly male, in their 60s, has had diabetes for a decade or more, and unfortunately they are a bit overweight. Again, the objective was to find out whether people were at risk for new onset kidney disease. So all of these people obviously have diabetes confirmed by laboratory tests, and their EGFR, which should be above 60 for a person who to be more or less fine from the renal point of view, is obviously above. And so it's a mean of 86, which is fine. There are, in addition to this, there are more variables for a total of 15. And so the input has the shape you saw before. Now for the output, as I said, we cannot know the outcome in real time. We need to hope that this person shows up and tells us how they are, how they're feeling. So this brings about 2 problems. First problem, as time goes on, it's very difficult to ascertain whether someone is fine or not, in that it's easy to see when events happen because all the outcomes accumulate, but then it's very rare that with longer prediction horizon, so you find a visit that confirms that their kidneys are fine because there's an obvious bias there. And so what happens, look at the first and last lines, is that we go from a 20 to 1, 0 to 1, so controls to cases, let's call it ratio, to a 1 to 10, which obviously is not ideal. And this is compounded with the fact that people skip visits. Remember the gray squares before. And not only that, so that introduces obviously a missingness in the outcome, but then you also got the normal right censoring, right, when they stop coming in because we haven't observed anything yet. And so this is the problem, right? We've got badly specified inputs and kind of uncertain outputs. So what do we do with that? Well, initially nothing is the thinking, right? So this is a deep learning model architecture. We hope that the model learns how to deal with these data that are objectively awful. So we just input them as they are. Since they're a sequence, right, a masked sequence, we can pass them through a recurrent layer. In this case, you can see the hyperparameters. This was a gated recurrent unit. And this will encode this matrix as a one-dimensional vector, which is what we want. Then we had a static variable, so we had male or female sex as the static variable, so we concatenated that and passed everything through a stack of fully connected layers with 7 outputs. These 7 outputs obviously correspond to the 7 years, to the 7 prediction horizons, that I showed you a moment ago. The way we deal with the interval sensor in the middle, so when we don't know what happened, is that we modified cost function, which was the usual binary average binary cross entropy, to work normally with zeros and ones. So when we know if the patient is fine or not. And then to null out the contribution to the gradient when the unknown outcomes come into play. So basically, by nulling out the contribution to the gradient, weights are not dependent on the unknown information, and that seems to work. However, it's kind of imprudent to go on like this, and so we added another layer of robustness that is a cumulative sum, such that from those trained outputs, we get the actual output of our model as a cumulative sum. That is, the first prediction horizon only uses the first neuron, but the 4-year prediction is the sum of the first 4 output neurons, which helps with those gaps in the outcome. So this is the architecture. First question, does it work? Well, obviously, yes, otherwise I would not be speaking to you today, and it works decently well because its area under the ROC curve ranges from 0.84 to almost 0.9, and it's consistently good at all prediction horizons. However, in a vacuum, this does not tell us much. And so, second question, are we sure that we need all of those dynamic data as an input? That is, the model, since it's more or less a black box, might be learning something like the average through time or something equally useless. So what happens if we change the test set? These are all data on the test set, about 3,000 people, and we invert the sequence of the visits. If the sequence were not important, so that if time were irrelevant, this wouldn't change anything. Instead, performance plummets, which is great because it means that the model is encoding what we want it to encode. Third question, do we need all these variables? Because there's a gold standard for a reason, right? EGFR works, and yes, EGFR works, but it works only in the short time, which is a problem when we want to intercept people when they're still healthy and we have time to, do something about their future kidney disease. Just as soon as we move slightly bit further away in the future from the baseline, well, our model works better, which is reassuring. And finally, are we sure that we need this massive architecture over there instead of, what the average clinician would do? So stack an imputer with a logistic regression and see if it works. Well, the answer is less clear in this case, probably because the inversion of ones to zeros that I mentioned before is kind of a factor there, but our model generally outperforms a series of 7 models trained specifically for each prediction horizon. So we're safe there as well. Which means that in conclusion, we developed this recurrent neural network to predict renal function impairment in people with diabetes, and the model works even if you use the data in regional format. More than that, the model works equally as well at all prediction horizons, and it beats all the benchmarks we came up with. So if I had to stress 3 main points, 3 advantages of this approach. First, it is robust to the presence of missing data and to regular visits and all of that at no extra cost, really, because we didn't really have to do any pre-processing. Second, is resistant to what I would call extreme interval censoring. So we don't know a lot of the outcomes through time, but still it works better than doing ad hoc models. And finally, and this is probably the most important thing, it has a high potential for deployment because again, we cannot modify data acquisition protocols and we need to adapt to them, and this model does exactly that, which is probably the main point of all of this. So this was it from me. Before answering any and all of your questions, I would like to thank my colleagues and mentors at the Department of Information Engineering and Medicine at the University of Padua. And having thanked them, I thank you all for the attention.